Well, good evening and welcome everyone to our webinar titled Maintenance Therapy Jitters, Understanding Right Place, Right Time, and How to Document Maintenance Appropriately, sponsored by Aegis Therapies. My name is Mary Saylor and I work in the Clinical Compliance Department at Aegis Therapies. My official job title is Medical Review and Denials Manager, but I'm also a physical therapist. I'll be presenting with Jacqueline Warschauer, who also works in the Clinical Compliance Department at Aegis Therapies and is the National Director of Medical Review and Quality Services. She's also a PT, and prior to working with us at Aegis, she was a medical reviewer for Medicare. Please note that you have all entered the webinar in listen-only mode, which means that your microphones were automatically muted. If you have questions, and we hope that you do, you may ask them at any time during the presentation via the questions feature in the GoToWebinar control panel, which is probably located in the top right-hand corner of your screen. Jacqueline and I will attempt to answer all questions at the end of the presentation. Also available on the GoToWebinar control panel are the webinar brochure and slide deck handout under the Handouts tab. Please feel free to download those. We recommend keeping a copy of the brochure with your attendance certificate in your records if you will be using CEUs from this session. You should receive your attendance certificate from Aegis within 1 week. Adhering to the information we submitted with our CEU requests, we'll be doing some informal polling intermittently during this session. This part is important. In order to receive CEUs for this webinar, you will need to answer every polling question. You don't have to answer them correctly, though if we're doing our job well, we think you will. So please participate in those polls when we get to them. We have received CEU approval for California and have several other CEU requests pending with other states. We'll update our brochure with those approvals as we receive them. Our cameras are turned on now for our introduction, but we'll be turning them off once we get started so the presentation content will be unobstructed. Upon completion of the webinar, we'll launch a post-course survey. You will also receive the survey via email. Please complete it and return it to us. Your feedback on this presentation and suggestions for future webinars would be greatly appreciated. Jacqueline, did I leave anything out?
I don't think so. I think we're good to go.
All right, great. Thanks. I won't read this disclaimer to you, but what it's essentially telling you is that we believe, to the best of our knowledge, that the information we will be sharing is accurate at this moment, today, October 19th, 2022. We cannot promise that it will be accurate anytime thereafter and encourage you to stay current with information and updates provided by CMS, their MACs, commercial payers, and state and national organizations on the topic. This next slide shows our anticipated learner outcomes, which are available to you in the slide deck handout, so I won't take up time reading through them here. No discussion about maintenance therapy would be complete without some mention of the JIMO settlement agreement from January 2013. Most of you probably already know that JIMO versus Sibelius was a federal court case that alleged that Medicare contractors were inappropriately applying an improvement standard when making claim determinations. Prior to the court ruling on the case, a settlement agreement was reached. Note that the settlement did not actually change any Medicare coverage guidelines or eligibility requirements. It simply upheld the patient's pre-existing right to receive reasonable and necessary care directed toward maintaining their condition or preventing or slowing their decline. On this slide, we have a few examples that show the regulatory support and the justification for providing maintenance therapy. We chose one from each of the 3 chapters of the Medicare Benefit Policy Manual that address the provision of therapy the most. Chapter 7 provides regulatory guidance for the provision of care in the home health setting. Chapter 8 is related to skilled inpatient care in the SNF setting, and Chapter 15 is related to outpatient services, which also includes Part B services in the SNF setting. You can see that the language between the 3 different settings is very similar between the 3 chapters. Each example discusses the different aspects related to review and determining whether or not a service is skilled and covered under CMS guidelines. In fact, if you read through these chapters, you'll see many areas where the language is nearly identical. Despite the JIMO settlement stating otherwise, you may still receive denials that include some language alluding to a lack of progress as the reason for the denial. If or when you receive such a denial, it is recommended that you review the pertinent chapter of the Medicare Benefit Policy Manual for your setting and that you cite the related regulatory language in your appeal. Maintenance therapy services may be provided in all inpatient and outpatient settings except inpatient rehab facilities and comprehensive outpatient rehab facilities, or CORFs. Those sub-bullets there are just listing the location of the regulatory language in the Code of Federal Regulations related to each of those restrictions. January of 2021 was an exciting time because this was the date when the 2021 Physician Fee Schedule final rule took effect, which gave assistants the ability to provide maintenance therapy to Medicare Part B patients. With this modification, assistants were allowed to provide maintenance therapy in all settings where maintenance therapy is covered. We like to use the term skilled maintenance to remind our therapists at Aegis that maintenance therapy must require their skills. These terms, skilled maintenance and maintenance therapy, can be used interchangeably, and you'll probably hear us go back and forth between both terms for the remainder of our time with you here today. The difference between rehabilitative therapy and maintenance therapy is marked in bold font for you. Rehabilitative therapy, just as the name suggests, must have goals written to improve function or underlying impairments, whereas skilled maintenance would have goals written not for improvement, but rather to maintain or slow a beneficiary's decline in function. The rest of the two definitions are pretty much identical. Both types of services must be so complex that they require the specific knowledge, skills, and abilities of licensed rehab professionals to provide the service, and therefore cannot be taught to and performed by an unskilled caregiver or by the patients themselves. Occasionally, we will have those patients that just don't perform as well for their unskilled caregivers or with an independent home exercise program as they do with us. But this would not be justification for rehabilitative or maintenance therapy. If the service could be performed by someone else, but the patient just prefers to have the service performed by their licensed therapist, this would be considered non-skilled therapy. When our skills are no longer required, it's no longer a skilled service. This table starts on this slide and continues on to the next slide because we wanted it to be big enough font so it would remain legible for you. I like the visual effect that it offers with the side-by-side comparisons of rehabilitative, maintenance, and non-skilled therapy. There really isn't much new information being provided here. We're just delivering the information in a different format for those of you that do better with this type of design. So again, just to recap, rehabilitative therapy must be performed by a licensed therapist or assistant. It would have goals to improve function, services must require the skills of a therapist, and a potential to achieve functional gains is also required. Maintenance therapy or skilled maintenance must also be performed by a licensed therapist or assistant, and the services must require the skills of a therapist. However, the goals would be established to maintain function or slow an anticipated decline in function, and there is therefore no expectation for improvement. Non-skilled therapy does not require the skills of or license of a therapist or assistant, does not require the potential for improvement, and goal requirements can vary based on situation or possible state Medicaid requirements. This portion of the table offers some extra detail that you haven't seen yet on the previous slides. Reimbursement can vary with rehabilitative therapy depending on setting and contract between a per CPT code, visit code, or per diem rate. And as previously mentioned, rehabilitative therapy services can be provided in all inpatient and outpatient therapy settings. Depending on payer, skilled maintenance may or may not be reimbursable, but if reimbursed, it could also be paid by CPT code, visit code, or per diem rates. It can be performed in all inpatient and outpatient therapy settings except inpatient rehab facilities and CORFs. And finally, non-skilled therapy may affect case mix index in some states or may have no reimbursement, but it can be performed in any location. It's time for our first poll question of the evening. Jacqueline's going to cue it up for us now. Please take a moment to read through it and give an answer.
All right, I'm going to go ahead and close the poll.
And there's our results. So overwhelmingly with the true answer, and that is the correct answer. So therapists can delegate skilled maintenance treatment to therapist assistants for both Part A and Part B patients. Nice job. Before we can talk specifically about maintenance therapy, we thought it would be good to first discuss what criteria must be met in order to classify therapy as quote unquote skilled. Let's start by looking at what Medicare has to say about it. The first and third citations here came from Chapter 15 of the Medicare Benefit Policy Manual. Remember, that's the Part B chapter. The second citation came from the SNF Part A chapter, or Chapter 8. While the wording varies a little between citations, there's a common theme here. They're describing a heightened level of service delivery that only we as therapists can provide. Clinician assessment, complex and sophisticated, requires the judgment, knowledge, and skills of a therapist, can be to improve, rehabilitative, maintain or prevent or slow decline, skilled maintenance of a condition. Here are a few more excerpts from the Medicare Benefit Policy Manual. Our services must be medically necessary and aligned with accepted standards of practice, continued assessment and analysis at regular intervals, leading to establishment of compensatory strategies or skills. If this is what Medicare is saying about therapist skill, then it stands to reason that these types of details should be present in our documentation, right? I think so. Let's go a little deeper on that complex and sophisticated piece. Sometimes an intervention requires our skills initially, but over time it can be learned and the patient and/or caregivers can demonstrate mastery of the skill and independence. Just because it was skilled in the beginning doesn't mean that it will always be skilled. We must continue to evaluate whether or not we're still needed. Just because we provide the service doesn't mean that someone else, someone less skilled, couldn't do the same thing. Again, do we have to be there? What would it look like if we weren't there? Would it be different? Would it be unsafe? If not, then it probably isn't skilled. Sometimes the task itself isn't super complex, but rather it is the patient's presentation that is complex. Maybe they have a fluctuating presentation. Maybe they're wildly impulsive and subsequently unsafe because we have to constantly be on guard and make split-second assessments and respond accordingly. If we were performing that same intervention for someone else, it wouldn't require us to be there participating, but for this patient, it can't happen without us. That would be the necessary distinction to make and explain in our documentation. Therapists ask all the time, can you just give us a list of what's skilled and what isn't? We'll follow it. Just tell me what to do. If only it were that easy. These things are skilled, these things aren't. Stick to the list. Except there isn't a list of skilled versus unskilled tasks. Each of those bulleted tasks, ADLs, assisted gait or mobility, therapeutic exercise, each of them can be skilled, might be skilled, but also might not be skilled. Consider also that often the skill in the treatment isn't lacking, but the skill in the documentation is. I think it comes down to this. As therapists, we are accustomed to being focused outside of ourselves. The patient is our number one focus. What is the patient doing? What are they having difficulty doing? What are their symptoms while they do it? We often fail to reflect on ourselves and all those things that we do so automatically and reflexively, and we forget that what we do is so special and couldn't be performed by someone else. Our observations are different than a family bystander. Our verbal and tactile prompts are in response to expert analysis. It's those things that we do and others can't do, that constitutes skill. This is just a list of potential skilled action words that can facilitate quality documentation. However, note that these words alone won't make it skilled. If we repeat the same action word, initiated, for example, when talking about the same initiated thing over and over again for weeks on end, does that still carry the same weight? Probably not. In fact, it's not even using the term initiated as the definition intends when we use it repetitively for the same initiated thing over and over again. Remember, what is skilled today may not be skilled tomorrow. These action words will get us started, but it will be the patient and point in time specific details that will drive the concept of skill home to the future readers of our documentation. A huge part of determining if something is skilled is to look at all the details of the situation. Again, skill is not task specific, it's situation specific. That's why it can feel a bit like a moving target. If you're feeling that way, hold on just another moment because I have something to share that will hopefully stabilize that target back into your sights again. While Jacqueline and I were discussing skill earlier this year, we had a bit of an epiphany. The clarity we were seeking lies in a handful of those buzzwords: assess, develop, analyze, and modify and progress. If each of those elements are present in an intervention, it's skilled. This isn't new conceptually, of course. When we audit documentation, our process has been structured for years to look for these components. We've just never drilled down in this way before to realize that these are the 4 cornerstones of skill. So if you're wondering if your services are still meeting skilled criteria, ask yourself these 4 questions. Are my skills as a therapist required to safely assess the patient's underlying impairments and functional deficits, develop a patient and point-in-time specific treatment plan for medically necessary services, analyze performance during interventions, and modify and/or progress the interventions in response to the analysis? If you answer yes to all 4 questions, the service is skilled. This slide lists some criteria that therapists often allow to cloud their vision and sway their skilled determination. Each of these circumstances are quite prevalent, but it's important we remind ourselves that these do not contribute to our decision about skill. If the patient and/or the caregiver has a history of non-compliance, or if we have concerns that they won't comply with a soon-to-be established program, this would not give us cause to continue to deliver the service and bill it to insurance after it is no longer skilled. It also often comes up that the caregivers are too busy to carry out a restorative program. They just don't have time. Unfortunately, CMS specifically addresses this in the Medicare Benefit Policy Manual and states, the unavailability of a caregiver will not make an otherwise unskilled service skilled. Some patients just prefer to work with us. Not just prefer, sometimes they will only work with us. And honestly, I've gotten attached to more than a few patients in my past that I didn't want to transition into anyone else's care either. Unfortunately, patient or caregiver preference gets no consideration when determining if a service is skilled. If we can't answer all 4 of those questions from the last slide with a yes, it no longer requires the skills of a therapist. We have 2 columns of therapy documentation examples here on this slide. The documentation listed on the left represents the type of notations that we sometimes see in medical records. Patient ambulated 50 feet with wheeled walker and minimal assistance. These are good details to document as they do give a picture of the patient and what they can or cannot do. However, it doesn't at all describe the components of skill that existed in the treatment. This type of documentation looks no different than honestly what an aide would report in a nursing home. It's beneficial to remember that reviewers will read therapy documentation and will compare what was provided by the therapist to what an aide could potentially have done. If it looks like an aide could provide that service, it won't be considered skilled. The documentation at the right reflects the skilled components of the treatment by documenting more detail about the therapist's actions during the intervention and their contributions to the treatment. Now, these are things that an aide would not know how to do. Stabilizing the hips during a specific phase of gait, timing verbal cues for foot clearance during another phase of gait. But it also reports those patient performance details we saw on the left. The version on the right looks better, right? So whether you're reviewing your own documentation or someone else's documentation, ask yourself, could an aide do or document this? Skilled versus teachable is another vexing concept for all of us as therapists. We say that if a service requires the skills that I learned in school and demonstrated in order to get my license, then it must be skilled. But that doesn't always play out because there are plenty of things that we learn to do in school that we can then teach our patients or caregivers to do. So the question is, when is something teachable and when is it not? If you answer yes to all 4 of the required skilled element questions, it would not be a teachable task because it still requires your active presence and participation, your skills. If you answered no to 1 or more of those questions, it's likely that it is a teachable service. So now if you can picture it, we have a 2-bucket system emerging, teachable services in one bucket versus skilled services in the other. This is a question we should be asking ourselves regularly throughout the episode of care for all interventions we provide. Is this a skilled service or a teachable service? Remember, something may be skilled today and teachable tomorrow, so we have to remember to assess and reassess. Tasks, exercises, techniques that will continue to benefit the patient but can be safely taught should be taught. If it can be taught, it should be. Once comprehension of the instructions and mastery of the teachable task has been demonstrated, it can be transitioned to an independent or supervised home exercise program or a caregiver program. Intermittent reassessment of that taught program can and should occur as needed throughout the episode of care to assess continued appropriateness and to make modifications or to progress if needed. Effective application of this analysis will enhance outcomes. Think of the quadruple aim. Outsourcing those tasks to the patient and or caregiver that no longer require our knowledge, skills, and attention will allow us to focus on and emphasize those things that only we can do. This will allow us to work at the top of our license and to be efficient with the time that we have with our patients. It's good for the patient, it's good for us, and if we document it well, the medical record will scream skilled services to anyone who reads it. And remember, since skill can originate from the complexity of our service or from the complexity of the patient, we need to review the services we're providing from both perspectives. If you determine through that analysis that something isn't teachable, consider this question: why isn't it teachable? Answering that question and documenting the details of the answer will likely assist you in explaining why it is skilled. Let's shift gears now toward repetition. If a patient has performed the same exercises under the instruction of their therapist every day this week, was that a skilled service? The answer is maybe yes, and maybe no. We'll find the true answer by going back to those 4 cornerstone components of skill. Was the expertise of that therapist required to safely assess the patient, develop the plan, analyze the patient's performance, and modify or progress the interventions? Again, if yes to all 4 questions, then yes, it was a skilled service, even with the repetition. Yet again, we find ourselves firmly planted in the gray. Repetition is a red flag, and it could be an indicator of lack of skill, but it isn't always a bad thing. So how do we decide? How do we know when it's probably not skilled and when it probably is skilled? The presence of probably is needed here because these aren't surface level decisions. They need to be point in time and patient specific. The full picture of the patient's deficits, challenges, medical complexity, and needed services must be considered before arriving at a decision. In the probably not skilled bucket, we see repetition by design. Think of the patient doing pendulum exercises for 4 weeks. Based on the post-op protocol, no matter how good the patient feels and how quickly they master the pendulum exercises, we will not be modifying that exercise program or progressing it to more challenging tasks. 4 weeks of this repetitive exercise would most likely not include those 4 required elements of skill. Even if the task is complex, if it requires no ongoing analysis, it would also probably not be skilled. Think about a complex gait assistance or lymphedema wrapping. And going back to those components that cloud our vision, noncompliance, unavailability of a helper, or patient caregiver preference would not qualify an unskilled repetitive task as skilled. Now on the other side of the slide, we have repetition that would most likely still qualify as skilled. Consider a repetitive task that is still being taught to the patient or caregiver, lymphedema wrapping, for example. The therapist might not be changing the wrapping approach, but it will probably take multiple sessions to teach the technique. The teaching of the technique, if clearly documented, would likely qualify the service as skilled. Maybe the technique isn't changing, but the patient is at such a level of complexity that analysis of their condition and their response to the repetitive task makes it skilled and something that only we as therapists can do. Or in that last example, sometimes the treatment concept is repetitive, range of motion, for example, but the performance of the treatment is not. Consider a patient that needs passive range of motion several times a week. The joints and directions of movement probably won't change, but the degree of movement, the force applied during the end range stretch or the duration of the stretch, or the manual techniques that are used from day to day may change based on the patient's presentation or tolerance. The analysis that leads the therapist to decide how to address each of those components, if clearly documented, would probably qualify the service as a skilled intervention. The content on this slide was pulled from real Medicare denials. Notice the language used. PT, OT, ST services do not qualify as skilled services. No longer at a level of complexity and sophistication. No longer requires the unique skills and judgment of a licensed professional. That last sentence in each decision is most applicable to our repetition discussion. This reviewer stated, specifically, the notes for the review period have described only repetitive services, encouragement, and support without furnishing any patient-specific detail that only a licensed professional would be equipped to provide. Or in the second example, they stated that repetition doesn't require a therapist and non-skilled personnel can provide functional maintenance programs. Clearly, repetition is a red flag for reviewers. So if you have a patient in which repetition is justified, it's imperative that you document that justification so you can avoid a denial like these on this slide. Okay, it's poll time again. Jacqueline, will you please queue up our next question for the group?
Yep. Okay, the poll should be coming open.
It is open.
All right, looks like it's starting to stabilize in answers. Last chance to get your answer in for the poll. All right, I'm going to go ahead and close and share.
And it was a landslide, and everybody got it right. So that's good. That means that I've really been a broken record on those 4 cornerstones of skill because they're really important. It's an important concept. So I'm glad that everybody was in agreement. That is a true statement. So now that we understand the skilled part of skilled maintenance, let's review considerations for setting up skilled maintenance. This is another Medicare citation. In the source document, it's written as a single sentence, but we've purposely broken it up here on the slide to highlight the 3 components that exist. In order to be considered skilled by Medicare, the services must be provided with an expectation that the condition will improve in a reasonable and predictable period of time. Or, note that or word, or the services must be necessary for the establishment of a safe and effective maintenance program. Here's another or the services must require the skills of a therapist to perform the maintenance program. It's those last 2 bullets highlighted in blue there that we want to focus on for skilled maintenance. I'll be quiet for a moment to let you read through these 2 examples. We already talked about the complexity of the patient sometimes meeting the criteria for skilled services. If someone keeps falling, no matter what we do, and it's next to impossible to teach a static plan because their needs and presentation are changing constantly, it might justify skilled maintenance. Or in the next example, we again have day-to-day variability, but this time the purpose of the interventions will be to slow an anticipated decline due to what we know about their Parkinson's diagnosis. This also would likely justify some degree of skilled maintenance services. This scenario describes a bit of a hybrid program. I'll give you a moment to read through this one. So in this example, an otherwise non-skilled exercise program can be initiated, but with periodic check-ins from the therapist to allow for education and fine-tuning. This type of oversight enhances the communication between caregivers and rehab and can result in subtle regressions being noted and addressed more quickly before true functional loss can occur. In this example, it's the intermittent oversight that is the skilled maintenance component. Unfortunately, there was no room on this slide for a title or a key. It's a busy slide, but we believe there's good content here, so I hope you'll give it a chance. This is a maintenance therapy decision tree to assist clinicians in determining whether or not maintenance therapy is appropriate. The first question box is shaded in green in the top left-hand corner. Blue shaded boxes are terminal boxes. Stop signs indicate the criteria for maintenance therapy have either not been met or additional information is needed before the final decision can be made. I won't read through it all, but what we've tried to do here is consider all the potential layers of details that either make something skilled or make it non-skilled. There's a pathway that addresses patients or caregivers preferring to learn the technique and to instead preferring not to learn the technique, and to instead have the therapist provide the service. We've already discussed that preference alone would not make it skilled. We often hear from therapists that skilled maintenance is needed for continued delivery of modality treatments. That could qualify for skilled maintenance, but only if repetitive delivery of that modality is evidence-based, and it would only warrant skilled maintenance for that modality, not for the other activities that may be performed before or after the modality. For the other activities to qualify as skilled maintenance, each of those individual activities must also require the skills of a therapist. Again, this decision tree is in the slide deck handout, so you have access to it if you've already downloaded it, or if you haven't yet, please do. I hope you find that it helps you to step out of that confusing gray area and into the clear black and white space. That's certainly what I prefer, black and white all day. This is where my portion of the presentation stops, so I'm going to now hand it over to Jacqueline to go over the documentation side of maintenance therapy.
All right, thank you, Mary. And I also want to remind folks that if you do have any questions, to go ahead and submit them in the questions field, and we will try to get to them after the session. A question we often receive is, can a patient be on skilled maintenance from start of care? And the answer is yes. There's nothing in the Medicare manuals that states a patient must first receive rehabilitative therapy before implementing maintenance therapy. The APTA states that skilled maintenance may be initiated at start of care as long as the documentation justifies the need. While it is arguably more common to transition from skilled rehab to skilled maintenance, this transition is not required. In my opinion, I don't think there are many patient situations that would be appropriate for skilled maintenance from start of care, but it can happen. When might we initiate skilled maintenance at start of care? Perhaps the patient is already familiar to us and we've had one or more failed attempts trying to establish and transition the patient to a safe and effective maintenance program because of the complexity of the program. Or perhaps the patient is new to us, but they or maybe their companion can communicate a patient history that obviously aligns with the need for skilled maintenance versus skilled rehab services. Please note, however, that while the patient's diagnosis is an important component of the patient's story that led them to you, The determination that skilled maintenance is required must be based upon the patient's need for the skills of a therapist, and not simply based on the presence of a chronic and debilitating diagnosis. The next two slides more specifically highlight the desired components of a skilled maintenance evaluation and plan of care. Much of the reason for referral statement will read like a rehab-focused reason for referral. The difference lies in that last bullet. Clearly connect how the reason for referral details support this patient's needs for skilled maintenance services specifically. Detailed functional assessments with standardized tests and measures are just as important for a skilled maintenance patient as for a rehab patient. Goals will be different from usual as they will not be written for progress. Similarly, the plan should remain focused on the skilled maintenance purpose. The recommended intervention should clearly require the skills of a therapist. The frequency can vary, and like all patient plans, should be patient-specific and aligned with the clinical assessment findings. Over time, skilled maintenance plans should be reassessed to confirm continued skilled need, and attempts should be made when appropriate to transition or at least titrate to a caregiver-assisted program. So now we're going to go into poll 3, and this time Mary's going to set that up.
Okay, I'll just give a 5-second warning here before we close the poll. Alrighty.
All right, looks like just about everybody answered false. And again, the question was because a patient has a chronic progressive condition such as Parkinson's, they automatically qualify for skilled maintenance. And that correct is not true because it's not diagnosis based, it's based upon the needs for the skills of a therapist. So thank you, Mary. This next section will go into a little more detail about supporting a transition from rehab therapy to skilled maintenance. Before discussing situations that qualify for a transition from rehab to skilled maintenance, let's take a moment to address a patient that plateaus. There will be times when a patient plateaus or even declines before the established goals for improvement are met. You must then determine the cause of the plateau. And if determined to be a temporary plateau, you should provide an updated treatment plan to reinvigorate progress toward the goals to improve. In some cases, you may determine that maximum benefit has been achieved and further goals to improve would be unreasonable. When you have goals to improve but the patient is not improving, it's not skilled maintenance. In fact, if you have a patient under a prolonged plateau while the goals are aimed at improving, it's possible that the Medicare coverage guidelines are not being met for either rehab therapy or skilled maintenance. And I think Medicare, when they rolled out the skilled maintenance interpretive guidelines, anticipated folks beginning to refer to slow progress or lack of progress towards goals to improve as skilled maintenance. According to Medicare, in regards to establishing treatment goals, the goals cannot be modified retrospectively. For example, when it becomes apparent that the initial treatment goal of restoration is no longer a reasonable one, the provider cannot retroactively alter the initial goal of treatment restoration to maintenance. Instead, it would make such a change on a prospective basis only. In other words, if a patient is not progressing toward the current goals to improve function, the therapist cannot and should not describe the services as skilled maintenance. Skilled maintenance is a planned approach to treatment that is aimed at goals established to maintain or slow the decline in function. When the patient has achieved his or her goals to improve or no longer has the potential to improve, you will need to determine the best path forward to maintain the gains achieved. Do you need to train a functional maintenance program for the patient, a caregiver, or restorative nursing to carry out? Or do you need to modify the goals and transition to skilled maintenance due to the patient's uniquely complex current condition or the complexity and sophistication of the interventions required to maintain function? Once the goals to improve have been met or deemed unachievable, it's often in the patient's best interest to have a follow-through program to maintain the gains made in therapy. Training the patient or a caregiver on a functional maintenance program should be completed while the final functional goals to improve are still being addressed. If the training of the functional maintenance program happens to occur after the goals to improve have already been met or deemed unachievable, then a goal must be established related to designing and training the FMP, and all other remaining short-term goals to improve function should be discontinued. Remember to adjust the frequency and duration to reflect the reduced visits needed simply to design and train the program. At the bottom of the slide, we've given some starter phrases that show how the FMP goals can be structured. Sometimes a reassessment of the FMP trained is warranted to ensure that the program is beneficial. If the patient will remain on caseload after the FMP training has been completed, in order to provide a planned reassessment in the future, a goal should be written surrounding the planned reassessment. In addition, the frequency and duration should be adjusted to reflect the timing of the planned reassessment. For some patients, our skills as therapists will be needed to carry out the program to maintain function or slow the decline. As mentioned, your interventions to maintain or slow decline will meet the covered skilled maintenance requirements if the patient's condition is so complex, or the interventions themselves are so complex and sophisticated that your therapist's knowledge, education, and training are required to safely and effectively carry out the services. We can't mention this enough. The coverage for skilled maintenance should never be based solely on the patient's diagnosis. For example, the patient has Parkinson's, therefore they automatically qualify for a skilled maintenance program. That statement is faulty thinking. Coverage is based on the need for your skill in carrying out the interventions. At the time of transition from a rehab therapy plan to a skilled maintenance plan, your clinical rationale is critical for justifying the transition to skilled maintenance. Justification is necessary to show that a therapist-designed skilled maintenance plan is required and must be performed by a skilled therapist. Your documentation should describe the specific medical conditions and clinical circumstances that make the patient complex. It is not sufficient to just state that the patient is complex, but rather the documentation must describe the circumstances that make the patient complex at the time of transition. Describe the complex and sophisticated treatments that will be needed. Describe these services in such a way that it will be very clear that the patient themselves or a spouse or caregiver could not safely and effectively carry out the services. Explain the risk to the patient if the therapist did not provide these services. For example, describe the specific functions that would decline and the result on patient's quality of life or burden on caregivers, and the consequences that would occur if the service was attempted by the patient themselves, an aide, or caregiver, and not carried out skillfully by you, the therapist. On this slide, I've given you some structure of what should be written to justify the transition from rehab therapy to skilled maintenance. Now this slide, it's in your handout, so I'm just going to go ahead and move along. And on the subsequent slide, I just filled in the structure from the previous slide. So I just put in a patient example. And again, this information is in your handout. When transitioning to skilled maintenance, be sure to adjust the short-term goals and the long-term goals to reflect the intent to maintain a certain level, or when there's a chronic progressive condition, to reflect the intent to slow the decline and keep the patient from falling below a certain level. There are common errors we see in skilled maintenance documentation at this time of transition. We've repeated a couple times that skilled maintenance goals should not be written for progress. Well, this sounds obvious and easy. I can tell you that as therapists, for us as therapists, writing goals for progress is really, it's second nature, right? That's what we do. We don't think about it, it just kind of naturally flows, right? Because we're therapists and we're programmed to help people to get better. So it does kind of take extra focus on our part to not fall into our usual rehab rhythm, and make sure that all goals are that are written for a purely skilled maintenance plan of care are actually written to maintain or slow the decline. Note that whether we are providing rehab care or skilled maintenance, the expectation for benefit of treatment remains. Goals should be appropriately written. And as such, if appropriately written, they should yield an excellent or good potential to meet those goals. If the goal is written to maintain function and the therapist wrote that the patient has a poor potential to maintain that function, the services would likely be deemed not reasonable and necessary upon review. Patients receiving skilled maintenance services must have the potential to achieve the goals to maintain or slow the decline in function. The documentation expectation for reporting potential and the prognostic indicators are the same for skilled maintenance services as it is for traditional therapy program designed to improve function. In both cases, the therapy potential relates to the chance that the patient will meet their long-term goals. The long-term goals, right, that you are writing, hopefully in conjunction with the patient. And the prognostic indicator relates to the positive attributes and conditions that the patient has in them or surrounding them that make you believe that the patient will actually meet the long-term goals established. Generally, a patient should have a good or excellent chance at achieving the goals established when the goals are appropriately written. When there's ongoing skilled maintenance services, the progress note timing and the progress note content general expectations are the same as for a rehab patient. For skilled maintenance services, progress notes should include analysis of why the short-term goals were or were not met to maintain or slow the decline in function. Analysis is not restating of measurements from the goals or documenting what the patient can or cannot do. Rather, analysis is the reason you believe as a skilled therapist why the goals to maintain were or were not achieved. For example, reasons for maintaining may be due to provision of a real specific skilled technique described that only a therapist could provide, which will allow the patient to maintain a specific ability. It's good in progress notes to also highlight the skilled services provided. Remember that coverage of skilled maintenance turns mainly on the patient's need for your skills. Therefore, take opportunities to highlight that skill in progress notes. Skilled services are treatments that are complex and sophisticated because they require your knowledge and expertise for analysis and adjustments. Be sure then to explain in your documentation why you, the skilled therapist, had to be there. Explain what you implemented, introduced, modified, adjusted, progressed, or revised based upon your analysis. Explain what you did in enough detail to show the complexity, such that the intervention required your knowledge and expertise that a non-therapist could not provide or provide safely and effectively. Sometimes over a progress reporting period, a patient condition can temporarily stabilize and your treatment approach has less variability based upon your clinical analysis of the patient's daily need. Explain in this type of situation why your skills are still needed on the context that you believe the patient's condition likely will resume variability again, requiring your skill to analyze and adjust the intervention to maintain function. As a reminder, repetitive activities, tasks, or exercises are generally not considered skilled. This is because repetitive activities, tasks, or exercises can be taught to the patient to do on their own or taught to someone else who is not a therapist to cue or help the patient. And just because a patient requires cues does not necessarily mean that the service is skilled. If the cues are repetitive, then a caregiver should be taught to provide the cues. If the cues are changing, then the documentation must support why the therapist is needed for analysis and adjustment of the cues. So here we are with poll 4. And Mary, can you go ahead and show it?
Yep, it should be up. Okay, just gonna give it another few seconds here. Last chance to cast your vote.
All right, a majority said that that was false, and that is the correct answer. So remember that skilled maintenance can only be done on a prospective basis going forward. So if someone had goals to improve and they aren't improving, you can't retroactively call it skilled maintenance. It's only on a prospective basis. It's a planned approach that have goals established for skilled maintenance. All right, thank you. All right, just going to kind of wrap up our last section on auditing skilled maintenance documentation. So I will tell you that because of some of the misunderstandings of what qualifies for skilled maintenance, I think it's good practice to have another set of eyes, such as a rehab director or clinical specialist, review the documentation and provide feedback to ensure that support for skilled maintenance is present. When auditing an evaluation that you believe is skilled maintenance, the first thing to look for is to verify that the long-term goals and short-term goals relate to maintaining or slowing the decline in function. If goals are to improve, then it's not skilled maintenance program. With that said, a treatment plan can be mixed to meet the patient's needs with some areas and goals aimed at improvement and some goals aimed at maintenance, but only if that is the intent of the therapist. When on a mixed treatment plan, best practice would be for the therapist to explicitly comment in the documentation that the patient's current treatment plan includes some areas that will focus on improvement and some areas that will focus on maintenance. Probably the most important area to look for is complex descriptions of the patient's condition or treatment needed, such that it would be clear that a non-therapist could not provide safely or effectively the treatment. And finally, check to see that the patient has potential to meet their goals to maintain or slow the functional decline. And one thing I didn't mention on this slide, I'm talking specifically about skilled maintenance at start of care and things to look at that point in time. When a patient is transitioning from rehab therapy to skilled maintenance, you will generally be looking for the same things as I noted on the last slide about the evaluation. You'll need to check the goals. You want to see that the patient's current condition or current treatment needs are described to show the complexity, such that the therapist's knowledge, education, and skills are required, and that the patient has potential to meet the goals to maintain or slow the decline. Once the patient has been under a skilled maintenance program for a while, audit the progress type notes. Verify that the long-term goals and short-term goals relate to maintaining or slowing the decline in function. Again, if the goals are to improve, then it's not skilled maintenance, and audit per your facility's guidelines for rehabilitative therapy. As you know, when a patient is under a skilled maintenance program, the expectation is not improvement. However, there is still an expectation that the patient is meeting their goals, whether those goals are to maintain progress or slow the decline in function related to a chronic progressive condition. For the second audit question, look to see if the patient is achieving most of their short-term goals. If they're not, you'll need to see an explanation from the therapist as to why the patient is not meeting short-term goals, and any updates to the treatment that will be provided in order to facilitate the patient meeting the maintenance goals going forward. Whether the patient is meeting their goals or not, there should be rationale documented for why the patient is or is not meeting most of their goals. For example, reasons for maintaining may be due to provision of a specific skill technique described in the documentation in such a way that it's clear that only a therapist could provide the technique, which allowed the patient to maintain a specific ability. It's good practice on progress notes to highlight the skilled services provided, keeping in mind the catchphrase analysis and adjustments. There should be evidence of analysis and adjustments being made, but the adjustments in skilled maintenance are often day-to-day and not in a progressive manner. A patient that has a complex condition for which safety must be monitored, such as a healing fracture or unstable blood pressure, or a condition that can vary daily in presentation, such as Parkinson's or MS, likely requires skilled analysis and adjustments from day to day as part of the skilled maintenance services. The documentation must convince anyone reading the medical record that only a therapist has the knowledge, education, and skill to carry out the treatments provided. When auditing, look for a highlight of adjustments made as a result of analysis and what the therapist was doing in treatment. Is there evidence of anything new, such as new exercises or activities or modified cues? Was there a change in the task segmentation focus, strategies used, or the focus on related impairments? Or is there evidence of modifications or adjustments to the exercise and activities already in place based on analysis? It may be that the modifications or adjustments are varying daily as a result of the patient's changing presentation, such as variability in blood pressure or tone, that must be monitored and analyzed to determine the specific treatment approach for that day. Keep in mind that if the documentation does not describe treatment that is complex and sophisticated, or does not describe a patient's condition that is so complex it would be unsafe or ineffective for even the best caregiver or aide to carry out the intervention, then the appropriate assumption is that the treatment is remaining the same and it's repetitive and unskilled. So this will be our final poll.
Should be up. We'll be wrapping up in just a few seconds, so if you haven't voted, make sure you get it in. Okay, closing the poll.
All right, so the answer is false. It is repetitive treatment is often considered unskilled, and remember that it's the skill that makes skilled maintenance a covered service. So our documentation must show that the treatments are not always the same. There's things that there's analysis and adjustments going on that must be shown in the documentation. So we hope you received a few takeaways from this presentation, that if you had any jitters related to implementing or providing skilled maintenance service, those jitters have now calmed. Keep in mind that skilled maintenance is a Medicare benefit, and as a benefit, there are guidelines that must be met to use the benefit. Most importantly, the patient's complex clinical condition requires treatment interventions that are so complex and sophisticated that they could only be provided by a therapist. And the services needed are directed towards established goals to maintain or slow the decline in function. So on behalf of Aegis Therapies, we'd like to thank you for attending our webinar. Please complete the post-course survey and provide your feedback and suggestions for future topics. We plan to do more of these in the future and hope you'll come back again and join us. Have a great evening, everyone.
So we actually have one question for anyone willing to stick around. I know we're at the end of our time, but the question is, I once had a patient that kept falling. Even when I kept him on a maintenance program, it didn't seem to reduce the amount of falls much due to high variability from Parkinson's disease and poor safety awareness. Would maintenance therapy still be justified here? Jacqueline, you want to take that one? You want me to?
Sure, I can at least get started. So because we know maintenance therapy is also covered for chronic progressive conditions, when Parkinson's can be a chronic progressive condition, it could be that the fact that you're maintaining and they're not having an increased number of falls could make it justified. So if you set your goals that because of chronic progressive condition, we're trying to maintain the number of falls and keep them, because we know that there's a likelihood that falls could increase. If your skills are needed to maintain, I mean, you hate to say this, to maintain their falls, because we don't want everyone to fall, but we know what happens. I think that would be okay. Any other thoughts, Mary?
No, I agree. I think the fact that that question was asked shows that tendency to want to make people better. We're wired for that, and it just flows automatically, and we're constantly being tugged back in that direction. So, yeah, I think that just kind of drives home what we were talking about. But other than that, you covered everything that I was thinking too. So we have another question. Can you comment on the fact that the frequency might change over time? To maintain a level of function may take less visits over time. In essence, the least dose that is still effective, like medication. It's important to understand this concept.
I'm just rereading the question.
Yeah.
Go ahead if you have thoughts, Mary.
I mean, I think that's true. I'm not sure that that's a question, more just this is what I think and can you confirm it? And I would agree that often we would see a decline in frequency over time, especially as we're transitioning from a rehabilitative program to a skilled maintenance program. But I don't think that frequency has a predetermined kind of definition. This many visits is good for skilled maintenance, or not any more than that, and it's not skilled. I think it does have to be patient specific, but we always want to be making sure that we're delivering only what is needed and not exceeding that.
And one of the things we did talk about is frequently reassessing the program and seeing if you can start transitioning things to other folks, or titrating, right? Titrating, trying to reduce frequency, because it helps to say, because at some point maybe, I think it's always worth trying to see if someone else can do it. And if you do, and it's not very successful, it doesn't mean you can do a straight discharge. Maybe you reduce to once a week or once every other week, and a caregiver is helping, and you're frequently checking in. See how that goes. And if they're doing all the right things and they're not maintaining, again, that might be justification to bring them back to your previous frequency again. But I think it is good practice. I always try to titrate and to hand off, because skilled maintenance, once you're on, it's not one of those things where it's expected that they're on the rest of their lives. We should be always reassessing and seeing if we can transition off of us. And for some patients, maybe they won't. But I think we have to periodically be trying.
So there's another question. How do we determine appropriate frequency per week? I feel like we touched on that it really needs to be patient specific and ultimately what is needed. I think I may have. What are the reasonable timeframes for short-term goals and long-term goals?
Oh, the question again, because I interrupted you, I
Sorry.
think, was reasonable timeframes for short-term goals and long-term goals,
Correct. Yes.
right? Short-term goals, I usually train. It's what you expect to achieve by, let's say, the next progress report in 10 visits, so a couple weeks or so. And long-term goals, at least we train that would be what would be set for, at the end of your plan of care. Like if you set your duration for 6 weeks, the long-term goal would be at 6 weeks. Now, unskilled maintenance, are your short-term goals and long-term goals going to be the same? Probably. Because in rehab therapy, we often say, set your short-term goals as stepping stones to long-term goals. Well, there isn't a stepping stone when it's maintenance, right? You're not trying to get increments of improvement. It's always the same. So in reality, often short-term goals and long-term goals will be the same. So it depends upon your policies on whether you have to do both short-term goals and long-term goals within your own organization.
And there's one other question that was hiding near the top that I missed. Can maintenance be provided under Part A? The first poll mentioned that PTAs can provide maintenance treatments for Part A and B.
You can for Part A, except for in inpatient rehab. But like SNF Part A, home health Part A, yes, skilled maintenance is covered.
Just scrolling through to make sure that we haven't. So one last one. It seems we're asked to predict what decline a patient would have without or with skilled maintenance in a time frame that isn't always predictable. How do we handle that? I would just
go ahead.
I was just going to say that, we're trying to predict things all the time as therapists. We're trying to predict how long it'll take to make progress. So I think that we just do the best that we can, make an educated guess based on the clinical presentation of the patient, what we know about them and their condition. And I think we adjust it if needed, if it doesn't seem like it ultimately is playing out the way that we expected it to, and explain it. That's part of our analysis when we do regular updates.
That's where I was going to with that one, Mary. So we did get a question on how to download the slides. So there should be a handouts tab in your little dashboard. And the slides should be in there as well as the brochure.
There's a question, how do we get a certificate for CEU purposes? And the attendance certificate will be sent out via email within a week. And I think Gerald was asking about the slides and says that he doesn't have that button. He's on the phone. There is an email on the first slide. Jacqueline, do you think you can zip back up maybe to our emails, and certainly if we receive an email requesting them, we can send them that way?
Yep.
A little clunky, but my email would be my name, Mary, Mary, .Saylor, Saylor, @aegistherapies.com. Oh, do we not have that on here?
No, we took it out.
So again, Mary, Mary, Saylor, S as in Sam, Aylor, @aegistherapies.com. So AEGIS THERAPIES.com. So if you make a note of that, my last name's easier than Jacqueline's, send it to me and I will happily forward you the file.
I see another question. If therapy is a qualifier for SNF Med A, can therapy transition to skilled maintenance? So yes, skilled maintenance can be provided under SNF Part A, but remember, the service, the patient must require a daily service. So it could be if the patient must have daily therapy, even if it's for skilled maintenance, then that might meet the criteria. But I will tell you, I often see skilled maintenance, at least in all the charts I review, I don't really often see people doing it daily. I'm not saying you can't, depending upon the patient's situation, right? So that's always the qualifier.
And I think that wraps us up for our questions. So again, thank you everyone for joining and for sticking around for the Q&A and participating. We appreciate it. Have a great night.
Thank you.